Good evening and welcome to Alternatives to Knee Arthroplasty, hosted by the HSS Education Institute. We have an amazing program planned for you this evening, which will begin with short presentations by both of our panelists, and then we'll transition into a discussion. During this program, we will address topics related to alternatives to knee replacement, including research and advancements in osteoarthritis treatment, surgical treatment options, and preventative measures. Again, my name is Adero Gaudin, and I am an orthopedic nurse here at HSS, and I work with patients following surgery. So today's guests are Dr. Andreas Gomoll, who is a double board certified doctor in orthopedic surgery and sports medicine, who specializes in the preservation or restoration of quality of life for patients with knee and shoulder injuries. I'm also delighted to extend a warm welcome to Mr. Tyler Moldoff, a doctor of physical therapy who provides care to patients with musculoskeletal conditions throughout the lifespan, from young athletes to older adults. We're glad to have you both here, and thank you for joining us today. So let's get started with Tyler, who will be presenting on osteoarthritis and both a pain science-informed and physiologic resiliency approach to managing the condition. Take it away, Tyler.
All right. Thank you so much, Adero, for the warm welcome. I really appreciate it. And I'm honored to be joined by such a fantastic panel and to be speaking to you all today. So let's get started on alternatives to knee arthroplasty from a physical therapist's perspective. I have nothing to disclose. So first, let's meet your knees. These are highly important joints. They are the largest weight-bearing joint in the human body. Their complex structure and function enable us as humans to move and adapt to our external environments. They include large muscle groups like the quadriceps and hamstrings that are responsible for transmitting large forces to accelerate our bodies in space. As a result of their critical role in human movement, they are a common site for pain and structural concerns, making them a leading joint for orthopedic surgeries. Now, it is important to understand that having structural changes in high-load joints, particularly our knee joints, is a normal process associated with aging. It turns out that most people over the age of 30 and onwards actually have structural changes, whether or not they're experiencing pain and dysfunction. More studies continue to show that having damage is normal and does not necessarily mean a person will be in pain and experience disability. I think this is a very important thing to understand. And you may be wondering then, if structural changes can be normal, then what causes the pain associated with knee osteoarthritis? Well, it turns out that pain is a complex phenomenon that is a result of communication between our nervous and immune systems. A good way to think of pain is like a fire alarm that sounds once there is a plausible threat of fire in a building. Recent studies show that increased presence of immune cells and inflammation is largely causal for osteoarthritis-related pain. A fascinating revelation over the recent few years is that inflammation can actually be initiated by the nervous system in the absence of additional structural injury. And now this suggests that the nervous system can activate the immune system, triggering inflammation and swelling when it feels that there is a perceived threat to your safety, sort of like a fire alarm in the presence of smoke. Now, systemic risk factors, including diabetes, metabolic syndrome, and cardiovascular disease, may make this alarm more sensitive. Additionally, with repeated flare-ups, the neuroimmune system may actually lower its threshold, even making it even more likely to experience future flare-ups. And in reaction, an individual, unfortunately, may unintentionally keep their alarm sensitive by practicing poor coping strategies. These include, but are not limited to, depressive and anxious thoughts, fearing movement, being sedentary, eating highly processed foods, smoking, and consuming excessive alcohol. Now, you may be asking, can we and how can we decrease the sensitivity of our neuroimmune alarm systems? Well, the answer is yes. And the answer also likely involves an integrative approach encapsulating many different factors and behavioral changes. So first, it is important to understand pain and its protective role in our bodies. This understanding alone may lead to more helpful responses during flare-ups. Studies have shown that knowledge of how pain works can improve our outlook and unlearn fear-driven ideas that keep us from improving our function. With this said, it is important to continue our meaningful movement behaviors, including walking. This study details a pain-informed graded walking program. It involves identifying the limit of our walking, whether it is step count, time, or distance, before we begin to feel high levels of pain that last for an extended period. Once we can reliably predict at what point we will feel a flare-up, for the following week, you'll walk at 80% of that limit. Then each subsequent week, you increase the walking by about 10%. This is one of the many pain-informed graded walking programs that do exist and are possible resources for someone who is looking to continue walking. If you ever went to PT, you'll learn that gaining strength in the muscles of the lower extremities is also a very helpful strategy in managing osteoarthritis pain. It turns out that activating our muscles regularly throughout the day promote the release of substances called myokines that circulate in our bloodstream and play a major role in managing inflammation. Also, studies show that 2 to 3 bouts of strength training per week utilizing body weight, weights, resistance bands can make meaningful improvements in pain and function. Throughout the day, you can do one or all of the following movements every 1 to 2 hours. As you can see on the left of the screen, sit to stands, seated calf raises, and also pushing the knees apart with a resistance band. And as I mentioned previously, there are systemic risk factors that are involved in the phenomenon of pain. It turns out that making sure we are adequately hydrated will not only improve our overall health, but also plays a major role in reducing osteoarthritis-related pain. To give yourself a fair shot, it is important to drink optimal levels of water and optimal levels of electrolytes to ensure adequate hydration. We are now learning the vital importance of healthy sleep patterns in maintaining our health, but also mitigating our pain related to osteoarthritis. Recent studies demonstrate that improving our sleep can improve the management of inflammation in our bodies and may lower symptoms of anxiety and depression that may lead to more healthy pain coping strategies in the presence of knee osteoarthritis. Interestingly, one of the most powerful tools to improve our sleep is actually getting outside first thing in the morning and getting sunlight in our eyes. Now, there's a lot of interest around a term called heart rate variability. This is the speeding up and slowing down of the heart rate between each beat. It turns out that when this is higher and it varies more frequently, it is a positive marker for emotional, neurologic, and cardiac health. It has been studied that higher heart rate variability may be associated with improved pain threshold and tolerance in osteoarthritis-related pain. New studies have demonstrated many avenues of improving heart rate variability, but one of the most accessible and easy tools to implement is actually to focus on slowing down our breathing regularly throughout the day. This means taking slower, meaningful, and rhythmic breaths, and this has the ability to influence our heart rate and also our pain experience. Lastly, I'd like to mention the gut microbiome and new studies that looked into its relationship with osteoarthritis-related pain. It turns out that having a more diverse and healthy population of certain bacterial species within our gut can reduce the pain associated with osteoarthritis. To do this, studies recommend eating the recommended amount of fiber that is present in colorful veggies and fruits. Also, fermented foods like Greek yogurt can bring high populations of good bacteria into our gut that reduce systemic inflammation. As you can see, maintaining the longevity of our knee joints may involve an integrative approach involving multiple behavioral changes that benefit the entire human body. It is likely that adopting at least some of these practices may make a meaningful impact on osteoarthritis-related pain. And there are several resources, and it's becoming a lot more popular to have this integrative systemic approach. Thank you all for your time, and I will send it back to you, Adero.
So now we have Dr. Gomoll. who will be presenting on surgical alternatives to arthroplasty.
Hello, and thanks very much for, I think I froze up for a second there. Thank you very much for joining, taking time out of your evening. Let me set this up for a sec. So I hope that is coming through and you can hear me. So when we say alternatives to arthroplasty, one thing I want to sort of get out in front, it's not that a knee replacement is a bad thing that shouldn't be done. But the problem is that a knee replacement is really for someone who has bone-on-bone arthritis and has terrible pain with activities of daily living that don't really respond to the interventions and modalities that Tyler had mentioned. So it's nothing to jump into, again, not because it's bad surgery, but because it's a little bit of a bigger surgery and because it is in a way, irreversible surgery. So we take out part of your knee and we replace that with a metal sort of replica of the original thing. And I speak in analogies all day long. And one of the analogies from real life that most people have some experience with is a dentist doing a crown. So you remove part of the tooth, that part was rotten, that's why you got rid of it in the first place, but that's irreversibly gone. And then as the dentist makes a crown and replaces that, you regain the function. And it's pretty good, but it's not the original tooth. So we are talking now about newer things that we can use pre-knee replacement. So for patients who are, for whatever reason, not ready or willing to have a knee replacement. And I wanted to show you two specific technologies. These are new technologies for old knees, and that is a shock absorber, which you see on the right side, which is, I mean, orthopedics is really carpentry and mechanics, and this feels like straight out of a car shop. And then something that feels sci-fi, this on the left, that is a plug made from coral. So coral from the sea, and the material coral is made of is called aragonite. So what I'd mentioned previously, this you are not ready, whether that's too active or too young for a replacement. Nonetheless, you may have sort of quote unquote knees that are much older than you, where you see a physician and they tell you you may be 20, 30, 40, 50, but wow, your knees really look like they're 70 or 80. And despite the knee being kind of old, we still don't like to do replacements in young patients. As I said, they're reversible, and the next operation you have after a knee replacement will always be another knee replacement. So ideally, we start that as late as we can. But how do we get you to this as late as we can? And that's what we call this osteoarthritis treatment gap. So if you develop knee pain, at some point you might just shrug it off, walk it off, you change what you do. Maybe you don't run marathons anymore. Maybe you just go for a light jog. But at some point it will become annoying enough that you go to a physician, they may take an x-ray and say, well, you have some arthritis. And then they start with all the non-surgical interventions in terms of making sure you sleep, you eat, you exercise the right way. And that can help. That can give you a few more miles, a few more years. Then you may step it up to injections called gel injections or hyaluronan injections. But how often can you really do these injections? I have a lot of patients who come in and they say they sort of work, but they're not great. They still have some symptoms. They still have to really limit what they do. And they would love to have something short of a knee replacement that helps them to feel better and maybe have a little bit more of an age-appropriate function. So this MRI image here is one of these examples. So a young person, 48, but an old knee. And what that looks like in his life was that he had a meniscus tear, and meniscus tears are really, really common. They don't all have to be treated surgically. Some of them are clinically silent, as Tyler explained. But if they really bother you, then you can do what's called meniscectomy, so trimming off the meniscus. And that's this word on the street that the meniscectomy is what makes arthritis. At least if the meniscectomy is well done, then you don't remove anything that's functional. So the meniscus tears like a hangnail, you get rid of the hangnail, which helps with your pain. But because the hangnail part wasn't functional, you don't make things worse. And the one that he had 8 years ago really helped because it removed the hangnail, and he was fine for a while. And then he had, again, knee pain. Maybe it wasn't the right thing to do, it was done somewhere else, but I don't want to do Monday morning quarterbacking. But he had another meniscectomy 2 years ago, and it didn't really feel any different. And part of that is that he had developed some arthritis. And on the image, this is the outer side, the lateral side of the knee, and that looks the way it should look with a healthy big meniscus. But then the inside has this really small meniscus, and where you see the white, this cartilage that's worn away. So it definitely has some arthritis, but it's not the bone-on-bone type of arthritis that we would treat with a knee replacement. So he had this typical cortisone injection, it's the abbreviation for that, CSI, and the gel injections a couple times, and it didn't really help. And then he was given a brace, it's called a medial unloading brace. It sort of pushes on the outside of your knee, and by pushing on the outside of your knee, it relieves some of the load, which is ultimately what causes the pain on the medial side. And most patients that I have that I give these braces have a love-hate relationship. They sometimes love what the unloading, like the function of the brace, does for them. They just hate that it's this external thing that they have to put on, and at some point it irritates your skin and it just gets in the way of hands and just getting around. So it works, but you don't really want to use that all the time. So historically, there wasn't really anything to do for this patient than try another round of injections and, well, take some Advil, and then people get heartburn, lose some weight, which is hard to do. Good thing, but hard to do. And essentially everyone is twiddling their thumbs until this arthritis has finally progressed to a level that everyone feels good about doing a replacement. But that sometimes can be 10 years. And if you have someone who's 48 and you force them to be in pain and limited function through their good years, 48 to 58, it's pretty frustrating. He has little kids, he's in work. So that's where we had developed this unloading device, and I helped them develop the technique, not the device, but how you put it in. So I do have, so my conflict with them is that I think this is a great device that helps. This is what that looks like. And like I said, this is straight out of a car shop, if you think about it. So it's a small absorber between these two foundations, if you will, that get screwed into bone. It's done through an incision that's 10 centimeters, so 4 inches long, which is much smaller than what a knee replacement incision is. And what it does is, it sort of does what this brace does externally, meaning it unloads the medial side. And unfortunately, it only exists for the medial, the inner side, not the outer lateral side. But the medial side is affected 10 to 1 in terms of arthritis. And it just reduces how much you load the damaged area. And if you load it less, it hurts less. And how you can imagine how that works is, if someone who has knee arthritis carries a heavy backpack, it hurts them more because you load it more. Forget about running, but if you're in the pool and you run in the water where you're not really weight bearing, or you're on an elliptical trainer where you don't have impact, or on a bike where you don't really have load bearing, you feel much better. You still move the joint, you still do things, but because you don't have to pounding as much, it hurts you much, much less. So the way we put this in is that when you have it fully straight, which is when you heel strike, when you usually hurt the most, then this absorber is a little polymer piece that loads, and that just bypasses force. So instead of going through the knee joint itself, it goes through the device directly from your femur down to your tibia, and it unloads about 1/3 of your body weight. So enough to really make a noticeable difference. But then when you bend it, bending usually, the weight bearing when you bend doesn't hurt. So then the absorber disengages so that you don't lose range of motion. And when they looked at one of the surgical alternatives, and I know in the program there was mention of the high tibial osteotomy, patients who have this osteotomy, which is a good operation that I do frequently, but people are on crutches really for 6 to 7 weeks, while with the shock absorber, you are off crutches very quickly. And for someone who has family work, it's important to be mobile again pretty quickly and not have this extended recovery. And most important, because we want a bridging option to get you older, still at some point need a replacement, but then at least when you're older. So in the trials, the testing showed that even after 5 years, 85% of patients still did not need a replacement, which is great. So it shows that it does what it's supposed to do. And this is my wife, Sabrina Strickland, in the middle. She's an orthopedic surgeon at HSS, and the first case that we had done over a year and a half ago, I think by now, we did together just because we wanted to do this as a family. And it was a patient who had a special type of meniscus tear or root tear, where we repaired the tear and then we unloaded. And then the sci-fi component, moving on to the next topic, is this coral implant, Aragonite implant. I have nothing to disclose besides participating in their trials. But coral is very similar to bone. You see a scanning electron microscope image, and you can't really distinguish that. Chemically, it's essentially the same, and it fully integrates in bone. This is a CT scan of an animal model where it was implanted before and after, and it essentially looks exactly the same. So these coral implants turn into human bone and get covered with cartilage. And this is an example of a patient where you can see this little coral plug implanted in a cartilage defect, which you can envision like a pothole in a street. So initially, there's no cartilage on top, and then over the course of 6 to 12 months, the coral turns into bone, and the defect pothole on top fills in with cartilage. This is what that looks like. It has these little holes, because these holes encourage bone marrow stem cells to turn into cartilage. So it's a very specific mechanism that does this. And this is one example of a 63-year-old, now 67. He was part of the trial, and he used to run marathons, and then he stepped off the curb, had a little hairline fracture, which you see as white, and just never recovered. And he had this implant as part of the trial, and this was at 4 years, where you can still see a little bit of a remnant of the plug, but nicely healed, and the cartilage defect on top has fully filled in with new repair tissue. This is another patient who had treated a little over 6 months ago, and she's 52. She had a pothole in the medial part of the knee, as well as in the front. So really more early arthritis, had responded to the gel injections. This is what these potholes look like during surgery. She had 2 plugs, and then she had a 6 months MRI scan recently, and you can see how, again, the plug turns into bone, and there's a really nice cartilage cap on top with thick cartilage, and she's doing great. So I just wanted to show this is my very diverse family. And as I mentioned, I do plenty of surgery with my wife together. But I wanted to share this with you. This is exciting new technology that is a beautiful example of what we do at HSS, because we not only participated in designing the trials or designing how this technology is surgically implanted, but we saw through the trials, and now we have it in clinical practice, and we can actually use it on you. And it sort of closes the circle really nicely from conception to implementation. And with that, I thank you all. I think we're going to have a little bit of a lively discussion.
And thank you again, Dr. Gomoll. Very informative. And thank you to Tyler again for your presentations. So now let's just dive on into our discussion, okay? And Tyler, what are some of the risk factors of knee arthritis? Can you share with us?
Yeah, thank you, Dr. Gomoll, for such a nice presentation, and thank you, Adero, for your question. So there's, a variety of modifiable and non-modifiable risk factors. So amongst the ones that are non-modifiable include things such as age, right? So as we get older, that's going to increase the risk. If you have a family history of advanced osteoarthritis, that may also increase your likelihood. But interestingly enough, amongst the more modifiable factors, things that we actually do have somewhat control of are things like our weight. As Dr. Gomoll mentioned, just carrying lesser load can put less load through the joints and may slow that likelihood. But also having metabolic diseases such as diabetes and similar may also increase that risk and likelihood of experiencing pain with osteoarthritis. And also things such as smoking and excessive alcohol intake.
Thank you, Tyler. Dr. Gomoll, what are the main reasons for not having a joint replacement?
One thing you mentioned is this osteoarthritis treatment gap, where people say, well, I look at your knee, I hear your symptoms, and like just focusing on the knee, that might qualify you for a knee replacement. But then when you take a step back and look at the whole person, then you may say, no, you're not really a candidate. So if someone who's 20 has a bad knee, you just don't do a replacement if there's anything else you can do. Because a replacement is a mechanical thing, so it has a little bit of a lifetime, the same way the tires on your car or the soles on your shoes. And when that wears down, which in young patients who use their joints more aggressively happens more quickly, then you have to do another one. And like your favorite coffee mug, if it breaks once, you glue it back together, and you can expect that to be a functioning mug. But the second, third, fourth time that thing breaks, at some point you're just left with a bunch of shards that you can't put back together. And joint replacement's a little the same. It's not that you can only have 3. It's just that they get increasingly difficult. So it's usually a combination of too young or too active that precludes a replacement.
And thank you for that, Dr. Gomoll. Tyler, when is physical therapy enough, and when do we encourage patients to seek alternative options?
Yeah, thank you. I think, well, to give physical therapy your best foot forward, if you will, is to really kind of go at it with a sense of hope that it is possible to avoid these procedures, as many of my patients are striving to do and accomplish. So I think that involves being adaptable and being willing to make some behavioral changes that are likely to increase your overall health, your outlook, your emotional health, and also, of course, implementing some of the movement behaviors that we suggest, but also, like I had mentioned about the increased graded walking program, I think it's important to utilize some of those structures. And I feel if at that point you've given it your best foot forward, you've really tried all the conservative options in conjunction with physical therapy, and you feel that it has just not responded in the way that was anticipated by the medical team, at that point, it would be wise to discuss further options with the medical doctor and the physical therapist as a collaborative unit.
Okay, thank you, Tyler. Dr. Gomoll, in regards to pharmacological interventions, injections, is something that I think all the audience would like to hear about. How successful are they, and how long do they provide relief?
So they're basically, I would say, 2 pots of injectables, if you will. One pot contains cortisone injections, and the other pot is everything else. So cortisone is quick, it's strong, it doesn't last very long. So if somebody overdid it this past weekend, they can hardly walk, the knee is really swollen and inflamed. Cortisone is a quick way of fighting that inflammation and bringing it back down. But that only works for flare-ups. If, on the other hand, somebody comes and says, my knee just hurts me all the time, it's not any better or worse now than it was a week, a month, 6 months ago, cortisone would just do like a 2-week damper on that, but then you're right back. So for that, we use the other pot, and the other pot contains, they're also anti-inflammatories, but they're milder, but more long-acting. And the one that's been the longest established is hyaluronan gel that I had mentioned before, hyaluronan is a substance that normal joint fluid contains, so it doesn't do any damage. It's sort of an organic thing that our body makes. That's been around for a long time. It's okay, it's not great. It works about 2 out of 3 patients, and it can last 6-ish months, call it 4 to 6. Most insurance companies cover it, but they only cover it twice a year. Other things that you can do are PRP, platelet-rich plasma. Unfortunately, insurance, that's why they don't pay for things. But that works kind of 3 out of 4. There's a lot of studies that show it works, some studies that show it doesn't really. And gel, I think my own patients, I usually try gel first because it's covered. If that works, great. If it doesn't work, then we may progress to the PRP. And then there's this whole stem cell area with bone marrow stem cells or fat stem cells. And I think that's the holy grail. A lot of places, unfortunately, have somewhat exuberant advertising with avoid knee replacement and delay and regrow your cartilage. It doesn't do that. Stem cells currently in use, injectable, do not regrow anything, but they can help modify pain and inflammation. But they are not any better than platelet-rich plasma, which is an easy blood draw rather than a procedure. So that's sort of a overview of the different pots.
Thank you, Dr. Gomoll. So Tyler, you spoke about weight loss. Do you see patients with improved joint pain and function after losing weight?
Yeah, great question. So, a common conversation point with some of my patients is like, should I lose weight? Should I drop weight? Well, in based on, the biomechanic factors that me and Dr. Gomoll had mentioned, increasing load on these painful joints, in theory, will likely increase pain. But the interesting thing about weight loss in 2024 is that it often encompasses a myriad of behavioral changes. Many of which I touched on briefly, right? Including improving your sleep, your hydration, certain nutritional factors within your diet. So I feel that those decisions may consequently lead to a reduction in weight, but at the same time, you're also likely improving your systemic health and your ability for your body to mitigate inflammation and better respond in a more adaptable way to some of these structural changes. So yes, in the sense that losing weight will take pressure off the joints, but also you'll likely make decisions that are just going to benefit your entire system and ability to manage inflammation.
And thank you.
And I'd like to add something, Tyler. That was great, but one of the frequent issues with weight loss, at least historically, people would starve themselves and they would drop weight. But whenever you do that, you lose as much muscle mass as you lose fat. And so you may be lighter overall, but you have less strength to support your joints. So you always want to combine weight loss with exercise. And ideally, you lose weight by exercising so that you can switch fat into muscle rather than just starving yourself, which is not really sustainable either.
Yeah, I'm happy you brought that up. Yeah, because it seems as though, and of course from the perspective of a physical therapist, that improving muscle mass is actually is a better form of weight loss. You'll naturally lose the fat mass in response and have a better distribution of weight. So thank you for mentioning that, Dr. Gomoll.
Oh, and thank you both. So I just kind of want to track back in regards to Dr. Gomoll, the knee shock absorbers. And how long does this absorber and Aragonite last? Does the patient get full knee replacement after a while? It's a double-part question.
So they both work a little differently. So the shock absorber is a mechanical thing. So they tested in the lab, and there it has sort of a 20-year lifespan, but 20 years is a long time. So I usually tell my patients this is more, call it a 7 to 10-year bridge. During that time, you feel better, you're more active, you still progress with your arthritis just as we all do as we get older, but then at least it's a more age-appropriate time. The coral, that, because it turns into a biologic tissue, so it's not really that has the same limited time span of a mechanical device. It's not as if that thing would break at some point, because your body makes it its own and maintains it. So failure there is usually more, again, you're getting older. The potholes that we treated were more the tip of the iceberg. More things come maybe in different places in your knee joint. So at some point, it's just more and more worn out. It's like you have a leaky tire, you fix it, doesn't mean that you can't get another leak. But usually also call it 7 to 10 years. It may be more, but
Okay. And I like to pull in I'm just going to pull in some questions from our viewers. They really want to know more about the Aragonite and how long has this been around and what are the success rates?
so around 10 years is when they started doing clinical trials, because the FDA is really careful and detail oriented before they let something onto the market. So they did smaller studies, randomized controlled trial, and based on that trial, it was approved. In terms of the success rate, generally the things we do are about 80 to 85% successful. And how do you judge success is generally the patient looking back and saying, I'm glad I did this, which means different things to different patients.
And who is a candidate for this procedure?
So if you're bone on bone, then the answer generally, again, depends a little bit on age, but generally is metal and plastic or replacement. It is more for this treatment gap, and whether you're 40, 50, 60, 70, it's not so much an age cutoff. It's more that I look at your joint, and if it's catastrophic, then you're better off with a replacement. But if it's too good for replacement, then we can talk about it. I know this is a very nebulous answer, but unfortunately, it's not a one size fits all.
Thank you for that. And what does the procedure and the downtime look like?
They are a little different for the two, but generally speaking, you're on crutches for about 2 weeks, because I ask you to unload the joint, let things calm down. After 2 weeks, probably if you do longer distances, you would still use a crutch to help out, but you can be what's called weight bearing is tolerated. So it becomes more a use the crutch if you feel it's helpful, but it's not that you must use it or that you would screw up anything if you didn't use it. None of these procedures you have an immediate bounce back, meaning the first 3 months you're a little slower. You may do stairs kind of one by one, and you wouldn't go for like a walk on the beach for a mile or two. So I think 3 months is a fair recovery, but it's not a complete recovery. And it's a little bit like if you do home renovation, like the first 80 and 90% or so seem to progress at a decent clip. So that's the first 3 months. But then you always have the little details, and whether it's in the knee or in the house, that can take a year, where you still work on strength, range of motion. It's a little stiff and achy. So that takes a while to work out the kinks.
Okay. And feel free, Tyler, please, and Dr. Gomoll. What about do supplements or collagen supplements work for knee osteoarthritis?
Paula, do you want to start out? I can jump in.
Yeah. I can't speak specifically to collagen supplements, although I have been seeing some buzz about their potential use in maintaining and helping cartilage and the health of our joints. But I think just kind of sticking with the basics and what is recommended to most adults in terms of just having a solid multivitamin, also getting enough vitamin D3, K2, and potentially use of omega-3 fatty acids, I think is a nice place to start. And of course, always best recommended to consult with your primary care physician, as well as an orthopedic medical doctor, just to make sure that regimen would work for you. But to my knowledge, in most situations, a multivitamin is at least a first step in the right direction, along with D3, K2 to improve the health of the bones that do encompass the joints.
Yeah, agreed. I mean, the first thing is always do no harm. So I think the recommendation to check with your physician to make sure there are no interactions. I mean, interactions between these things and medications are rare, but not unheard of. So turmeric, for example, is a very common sort of natural anti-inflammatory that some studies have shown really can help, call it take the edge off in terms of the stiffness, the ache that you feel. And to be honest, I take that too, just because I'm 53. When I get up in the morning, everything feels a little achy and stiff. And I do feel that that helps. But there are some interactions with tamoxifen and other medications where you really want to check. I like that you mentioned omega-3. Fish oil or vitamin E have long been used as anti-inflammatories, and they're also good for cardiovascular health. So that's a good thing. And then glucosamine and chondroitin sulfate, there's a little bit conflicting evidence. It doesn't do anything bad. How much it helps, I have some patients who swear by it, and other people who said they tried it and it didn't do a thing. But that doesn't do any harm. So that, but my recommendation is to try these, and you have to give it a few weeks. So it's not like an Advil where you take one and then you feel better like half an hour later.
Thank you both. And we just have room for one more question. So to the both of you, what is the next frontier? What is the future of knee preservation?
The Holy Grail, which I'm not sure we'll get there in my professional lifetime, but I had mentioned stem cells. It would be fantastic to get an injection that somehow can repair damage. I think that's a lot to ask of cells to inject them into this, in comparison, gigantic joint. It's almost like dropping off a construction crew in the US and say, well, fix it. Like, how do you tell the cells what to fix? I think the near-term goals are procedures that I showed you, where you can bridge to an older age. And it's not only important for you specifically to start these things at an older age, but if I can help you avoid 10 years of not avoid, but if you can leapfrog 10 years of research and development in replacement. So even if you still end up with a replacement, but if it's a better replacement with lower infection rate, longer durability, that's worthwhile too. So, I'd love to hit it out of the park, but for the most part, you go sort of by singles and doubles. But at least we see a constant flow of that. So we'll have more things in 3 and 5 years than we have today or had yesterday.
Tyler, do you have anything to add before we close out?
Yeah, thank you, Dr. Gomoll, for that info. And honestly, it seems that in 2024 and onward, it seems that there's an increased collaboration between different medical professions and easier access to communication between the professions. So I think the real, holy grail, if you will, of medicine is just having increased communication between a team of medical professionals that are working for you and individualizing their care to your needs. And that takes into account your lifestyle, your genetics, your risk factors. And I think that with the tried and true impacts of certain medicines, exercise and strengthening within my realm of physical therapy and improving your range of motion, but then also even consulting and having information coming from psychology and some of the research that they're giving and how improving your emotional health, improving your familial relationships, your friendships, practicing feeling good and thinking good thoughts and eating well seem to just really help the entire picture come together to improve your overall health. So I think that's the major goal in medicine that we're heading towards, and identifying risk factors earlier, having a team of doctors looking at you from start to finish in order to try to mitigate the effects of aging and all the other things that we're exposed to in this crazy world.
Thank you, Tyler. And again, thank you to the both of you for such informative presentations and discussion.